Good morning. I hope everyone had a really good night's sleep, and thank you to each and every one of you. I know some of you have travelled from near, some from afar, all the time, the flight delays and everything else, but thank you very, very much for making this great effort to join us this weekend. It's almost like having a family get-together, isn't it? We're now into year 3, and it's everybody, I feel we get so connected. We obviously have one thing in common, and that's amyloidosis. And as we all know, amyloidosis takes many forms, and but we're all connected by that one little friendly lady by the name of Amy, as I used to call her. So welcome, thank you very much, everyone. And without further ado, we're going to be chatting, having a discussion with regards to what we're doing in terms of amyloidosis, and I would like to introduce Fernando, and please introduce yourself and just, yeah.
Thank you so much, first of all, for the invite. This is a great opportunity to not only be able to share what we're doing, but also to hear your perspective. So I'm Fernando Rivera. I'm a clinical cardiologist working in cardio-oncology, cardiac rehab, located at the University Health Network and the University of Toronto.
Hi, is this on? Can you hear me?
Yep.
Yes. Hi, I'm Kathleen Turner, and I'm a dietitian. And I work at the University of Ottawa Heart Institute in the cardiac rehab program, and have been working more and more with some of the amyloidosis patients, and I'm happy to be here.
My name's Freya Kelly, and I'm a registered nurse also at the Heart Institute, and I help oversee our cardiac amyloid clinic.
I always said I have a pretty big mouth, but I guess I'll use the... Can you hear me?
Yep.
Okay. So I'm Deb Bosley. I'm one of the nurse clinicians in the Calgary South Health Campus Hospital. I've been doing cardiac amyloid for, seems like ever, but about the last 13 years, direct patient care. And I work with some colleagues, and Dr. Noel Fine, Robert Miller, and a couple of them are sitting back there. So I hope you enjoy our discussion.
So to kick off our supportive care for amyloidosis, let me ask the panel, from your perspective, what are the most critical supportive care needs for amyloidosis patients? So it's open forum, so feel free to...
That's really a tough one, because these patients are so complex. So trying to provide them all the supportive care that they need and want, and it's just tough. I think the most critical one for me anyway as a nurse is just to be there for them. I get many phone calls every day, and I answer my phone, and I just try to be there for them and answer their questions and do the best I can to maybe ease a little bit of an anxiety, because this is just a terrible disease, and so many factors go into it,
Priya?
Yeah, I was just going to sort of echo what you say, just having a nurse almost navigator, because there's so many components that are involved, especially with the patient with cardiac amyloid and other forms of amyloidosis. So having like a point person to sort of help, and as you go along your trajectory, sort of different things come up, arrhythmias or these exacerbations, and it's hard to tell someone right at the time of diagnosis all that's going to maybe happen, but being there as things are happening and explaining it to them and pointing them in the right direction. And I'm very fortunate linking them with Anne-Marie as they more sort of psychosocial issues come up.
Mm-hmm.
I'll add to that. Freya and I had a little laugh because we both said, what did you say to that first question? And she's a nurse, and she's like, I said nursing, and I'm a dietitian. I said, definitely dietitian. So We obviously give them with their own perspectives, but I think a lot of programs don't necessarily have allied health support, and they need that allied health support, right? So, as a dietitian, I often help navigate the changes that happen around digestion, absorption, the GI symptoms you might be living with, as well. Again, I work primarily with the cardiac amyloid patients or people who have cardiac amyloidosis, and there's a lot of food and nutrition stuff that comes up, and that support, having that available. And of course, we also work with PTs and OTs and social workers who don't always have time dedicated to patients who are living with this disease. And so I think that's a big area that we could fund better.
Yeah, and just adding to what I just already mentioned, I think we try to, from a more clinical perspective, to think beyond what is the pharmacological therapies. Now, what else can we do beyond prescribing medication? And complements very well with what has been mentioned. From my perspective that I work in cardiac rehabilitation, this is a strategy we're going to discuss a little bit ahead, that we need to take the nutrition, the psychosocial support of patient, exercise, behavioral modification, right? Because as we know, it's not only the disease, it's everything else that's coming. There are patients with arrhythmias, there are patients that have diabetes, hypertension, or they can have other comorbidities. So that comprehensive care and multidisciplinary approach is very helpful. Obviously, it's important to try to find who's going to be your champion that is going to help you derivate to the different specialties or to the different support care groups. Sometimes, like in programs, we have all that support in the same house, but sometimes we just need to find it across the clinics where you are located.
Excellent. And then, in terms of the roles intersecting, you've got the clinical side of things. Often the cardiologists, neurologists, they don't have the time to be able to go through all the different steps of amyloidosis to the patient upon diagnosis. And further to that, when a patient's told initially they've got amyloidosis, irrespective of what kind it is, they're overwhelmed, and you can't give too much information on that very first meeting because it's just too much. They're in shock at the time. And what you probably find is that fortunately we have people like Deborah, Freya and Colleen to be able to explain a little bit further as to what amyloidosis is, what it does and how it unfolds. But can you share maybe, for example, an example of a multidisciplinary, sorry, I haven't been drinking, not yet, approach that any of you have had that you've found has worked really, really well for a particular patient or patients, yeah. And again, it's just open to whoever would like to have a look. And I promise I won't keep staring at you, Deb. I said I won't keep staring at you, Deb. Okay.
So Freya and I were talking, so Freya and I work together at the Heart Institute, so we have lots of sort of shared experiences and shared patients, but one example we thought of, so one of the things that happens, as many of you folks are aware with amyloidosis, is that malnutrition is very prevalent, but we don't hear a lot about that. So in preparing for today's session, I actually found that malnutrition exists in anywhere from 25 to 60% of people who are living with amyloidosis, which is pretty significant, right? And I'll come back to this later, but also beyond the physical, there's all kinds of ramifications for how that impacts social life and time with friends and family, and nutrition is important for beyond just the physical. But a great example of when we had a patient who was malnourished, not eating well, low appetite, and this was distressing for this person, which is fair. I mean, someone who's enjoyed food their whole life, and then all of a sudden you lose your appetite, food becomes unappealing, and so we actually worked the pharmacist and the physician to trial an appetite stimulant with that patient to see whether or not that would help the enjoyment of food piece. And again, because there's so little research in the area of nutrition and amyloidosis, we were like, there's nothing out there, so we'll give it a go. But that's a great example of working not only with nurse and dietitian, but we involve pharmacy and the whole team to figure out if that would be a good option for that person.
And I think that's important because, as Ciris mentioned, we don't have a lot of guidelines for this, and everybody's very different with this disease, right? So we cannot generalize what we should do, what is best, what is the amount of calories that each patient needs, as you might know. So I think it's important that at least you try to have that individual approach, that you can get somebody giving you advice in your current situation. Sometimes as clinicians, what we have a lot of issues is with managing fluids, right? And sometimes we need that support to understand not only how much water are we drinking, but what other food are we drinking. Like yesterday, I was asked by a patient that he didn't know that the soup counted for the fluid restriction, or things like that, that maybe might be very obvious, but having somebody else that can give you some guidance, and a specific guidance, as everybody will be very different, is needed.
I was just gonna add to what Ray had said. When you talk about the role of nurses and dietitians, I mean, it's not just nurses and dietitians that take care of these patients. It's GI docs, it's cardiologists, it's neurologists. You know, the roles differ for all of us, but as nurses, I think we play such an important role in the patient's lives because we're the main contact for a lot of clinics across Canada. So we're kind of like the driver, and we just direct the traffic to the cardiologists, to the GI docs, to the dietitians, because we're obviously not experts in those areas. We need the help from all the different disciplines. So that's all I wanted to add.
And do you know if there's any other disciplines that have an impact on supportive care for amyloidosis patients? And if so, what role do they play outside of what we've just discussed? Okay.
You had a list because Ray had a list. I didn't make a list, but I mean, there's cardiac rehab that plays a role in our patients. We've just started in the last year to refer to cardiac rehab because most of our patients, as you probably know, suffer terribly from fatigue. They're so tired all the time, and we have found in the last year that the patients that have attended cardiac rehab actually feel better. So it's working a bit anyway in Calgary for some patients. I'm not saying it's a cure for all of them, but that one helps. We have dietary, GI docs, neuro docs. We have pharmacists that support us. I'm trying to think of who else. There's so many. It's so complex.
No, I agree with that. And to your point about the fatigue, that's sort of one of the more challenging symptoms to manage with this patient population. And again, there's not a lot of literature out there for why patients are so fatigued or how to help them with it. But I do always suggest, physiotherapy. We use Ontario Health at Home. I don't know what it is elsewhere in Canada, but they have physiotherapists who are able to come into the home and give more of a prescribed plan, I guess. And then again, Kathleen and I were chatting how we're so fortunate at the Heart Institute. We do have an in-house cardiac rehab, but I do recognize that that's not the case, again, elsewhere, even in Ontario or across Canada. But yeah, I think physiotherapy for sure plays a huge role in helping manage, especially the fatigue, which is so common in these patients.
And I'll add to that too, there's this psychology and social work piece because, again, we're fortunate at the Heart Institute, we do have a psychologist and a social worker on our cardiac rehab team, but there's a lot of emotional pieces that go along with this diagnosis. And not only just the new diagnosis, but living with the diagnosis. And, fatigue has come up a lot, and I hear that as well from my patients. But, how do you live the best life that you can? And our social workers and psychologists can provide a lot of support for that.
Yeah.
And I'm going to just go a little bit more with the fatigue and the cardiac rehab program. This is exactly what we are doing. We started an initiative, it was 3 years ago, with support of the industry to start doing a pilot group of cardiac rehabilitation. We work along with colleagues from Calgary, from London, Ontario, across to BC, and just to start understanding how we can start making these services available, because in the past, it was not a natural referral that could be done from cardiology or neurology. So now we know that cardiac rehab is feasible. We have done it here in our program in Toronto. We have over 25 participants that have participated, completed, and exercise is safe. The thing is how we're going to do it, and part of what is being mentioned about the fatigue comes as well from the natural disease itself, the involvement of the heart, the nerves, but also is a natural process of the body, right? If we stop moving, if we stop doing things, the body starts getting weaker, and this becomes like a vicious cycle that if we don't break, we don't get out of it, and there's no medication that can treat fatigue. The only way to improve fatigue is with physical activity. And that's where, along with the medical therapy, obviously we want to control symptoms, we want to make sure that all our patients are stable, they are receiving the treatment that they need to stop the progression of the disease, but at the same time we need to start seeing what else can we do. And that's what exercise, and we can think in exercise as a very, proper intervention, very intense, and it doesn't have to be like that, right? Any type of movement works. Obviously, if for certain things we do need physiotherapy because we can have a spinal stenosis, we can have a specific things that we need physiotherapy, but also we need a proper prescription of exercise. And we need to set up goals. Even if they're very small, the goals will help getting us there. And we have seen a very good improvement from our patients, the capacity to exercise to improve, and it's without even changing what is happening in the heart, because what we are working is with the rest of the body, and then we are allowing the heart to work better and to put less strain of the heart. So I think seeking for those opportunities, somebody that feels comfortable and slowly progressing the activities will be very, very helpful.
Can I just add one more group to that? Would be occupational therapists, which I think we often don't talk about or think about, but occupational therapists are great at working with folks to help them figure out how to maximize their energy so that they can do whatever they're able to do within that best time of day. And we don't, at our program, have an OT in our program, but we do have a vocational therapist who has OT as her background, so we often work together because, again, with food and nutrition, if you don't have any energy, it's really hard to prepare food, right? So working as well with the OT, which is a group who, I think can bring a lot to this table for sure.
Yeah. And some great points there in terms of the cardiac rehabilitation, because basically depending on the person will depend on what kind of exercise they can do. Some people can do very, very little, and that's okay, but at least it gets them some form of movement, some form of exercise, and that helps them emotionally as well. I mean, you've got the physical thing, which is great, but emotionally it's very, very important that their spirits are lifted. So that's absolutely awesome when we do that. And it's good to know that that's the way we're addressing things. Something that comes up quite often from a lot of the patients is the lack of gastroenterologists regarding amyloidosis. And as we know, in terms of the autonomic function, or dysfunction as I call it, there's some real horrible symptoms to that. And often patients struggle terribly. What do they eat? And they've tried eliminating so many different things from their diet. They then start using other things in their diet, and nothing really makes a difference to that aspect of it. Is there any comments or anything that maybe help someone in terms of that aspect of things?
I feel like I'm doing a lot of talking here, but I'm going to chime in again. So I'm the dietitian, and again, often I'm helping patients to manage those symptoms. So my role is not to treat those symptoms, but it is to help people live with those symptoms. And a lot of it is trial and error, like Anne-Marie said. So, it's, I'll have somebody come in and say, I'm having this symptom, so we'll look at what are the best things to manage that symptom, but also within the context of your life, right? Because when we make suggestions, they have to work for you and for what's going to happen or work best for you in your life. So we're really I'm really managing symptoms along with the patient. So figuring out what works. It's a lot of trial and error, but at least, we can support them through that trial and error. But it's, again, managing the symptoms, whether that's constipation or diarrhea, and the sort of nutrition interventions are going to be different depending on what that that is. And one of the big ones that I see all the time is really lack of appetite, and that's really distressing for people. So if you're someone who has loved food your whole life, and then all of a sudden you're like, I never want to look at food, I never want to eat, it's really upsetting for folks. And so I try to work with them around, how do we make changes that are going to work, but also sometimes I'm doing a lot of unlearning about everything they've probably heard a dietitian say in the past. So, my priority is to help them keep their calorie intake up and, perhaps regain some weight that they've lost. And so I'm like, all that stuff you've heard me say a million times about eating lots of vegetables, for now, I want you to throw that out the window. And that's also a hard thing to wrap your head around, right? If you've been practicing or eating a certain way your whole life, and now someone's saying, wait a minute, now I want you to eat ice cream. We do other things too, but we do recommend, working with what is able to be enjoyable and tolerable.
I'd actually like to hear more about your GI specialist, because I was very disheartened earlier on when we started our own clinic, because I think we sent maybe a handful of patients to our GIs, and they were very quickly sent back. There was either nothing they could do or nothing that they thought was actually happening with the patients. And so I'd love to hear more what you guys have.
Well, I'll say that we had a GI physician that was interested in amyloidosis in Calgary. Unfortunately, he's moved on. One of the gaps in healthcare in Calgary is you can send all the GI referrals you want to, but 6 months later the patient still is waiting to be seen, and that's just the hard fact of it. So in the interim, we advise them, just like Kathleen said, throw away the vegetables. Just eat what you want to eat and get some calories in, even though you're not hungry and your appetite is poor. If there's something you want to eat it, because you just need to. You can't be worried about putting on a few pounds or not eating right, or too much cholesterol or too many fats. You just have to eat. So unfortunately, that's our problem in Calgary right now, is that they wait so long, and it's terrible. But we do the best we can in the interim. And you're right, when they do end up seeing the GI doc, they don't know what to do with these patients either. So they end up usually seeing them one time and then, sorry, we can't really help you, here's our recommendations, and they don't ever see them again. So.
And that leaves a huge psychological impact on many of the patients.
Absolutely.
And it doesn't matter whether you're dealing with the constipation or diarrhea, both have horrible social impacts, which affects the person from being a bit of a social person too, because they're so often scared to go out.
Yep.
Because they don't know if they're going to get caught in transit, as you will.
Yep.
So there's a huge aspect to that. And to your point, Deborah, waiting 6 months for the referral, that's a huge amount of time that's spent for an amyloidosis patient to try and get things back on track, or to get some sort of appetite going, for want of a better word. And I love your point with regards to, I have my days, and there's sometimes I have those days I cannot eat, and my husband will say, what about ice cream? And I'll say, no problem with that, because it gets the calories, right? And at least you're getting some nutrition.
Yep.
Maybe not all that you really, well, it's not all that we need, but at the same time, if you've got to get by on things like that, to hang with it. Rather have something than have nothing. And that's my motto today.
Yep.
And deal with the rest as we will. Yep.
Yep, absolutely. Yep.
But thank you. What are the current challenges and gaps that you see in terms of trying to get patient education out there for supportive care?
I'm going to start. There are many challenges, because first of all, we need to get the support to the patients. As we said, to get to see the specialist sometimes is very hard, if not impossible, right? And there are no proper guidelines of what should be done. So at least we need to use what I will say is our local resources. I think we all come from institutions that we are very privileged, that we have amazing support systems and amazing education online, from the different programs, I think that's great. And sometimes that's what we need to look for, right? If you're in a center, they have those supports. Ask questions. Ask what kind of materials are available. Because, for example, in our case, we have a website that's completely free that talks about how to start doing exercise, includes resistance training exercises, the nutritional part. We have a beautiful manual, the psychosocial support. We have workshops that are online. And they're free for anybody, right? And a lot of these materials are even translated in different languages. The idea is how we get to those, right? And sometimes what we do is to make them available and at least to tell our patients, if you need more, this is something that you can read that at least is reliable. Not everything will apply, obviously, but at least we can translate certain things to what might work for each person. But it is a challenge.
I think maybe to expand a little bit on that is to try and bring in primary care a little bit into this, because we track a lot of our data, and one of the metrics that we just started tracking was whether a patient has primary care provider or not. And in my head, like, they have to get to such a specialized clinic. A lot of them do have to have a primary care provider to have gotten them there. But the reality is a lot of patients in Ontario anyways don't have a primary care provider. And so how can we bring what we're educating to our patients in here, but to primary care as well, where they already have so much, but there's a lot that I'm sure a lot of patients who are going undetected for a long period of time until they end up in the emergency department. And so I think making sure that we're including those key players in these kinds of conversations is really instrumental.
Maybe I'm just going to go back to part of the activities of the foundation that I always found incredible, like the webinars that has been done. These are great opportunities to connect patients with healthcare providers and to help getting guidance in things. So if you're participating here, so maybe we're a little bit biased, but if you know anybody else that is interested, direct them to the foundation as well. I think there's a lot of education support, at least maybe not the material, but to help them connect into different specialty clinics across Canada.
It just helps them. It just helps patients, especially initially, of that not feeling alone and on their own, because that's a huge thing initially, because most people have never heard of amyloidosis. So when they get that diagnosis, it's like a foreign language to them. They've got no idea where to start. Where do you go? What to do? So to have a resource like you've got, Fernando, is absolutely amazing. It's great. At least they can take bits and they can do it at their own time, in their own pace, and bit by bit help themselves. Yeah.
I think one of the other challenges when providing education, especially, for so many folks, the symptoms that you experience are so individual, right? And so a lot of what we do is tailor the generic information to something that works for you. And so often it can be really hard to provide all that information or as education in a generic form. And that's true of many chronic diseases, but certainly something we see a lot with this population. And, most folks really need some one-on-one support from a nursing team, allied health team, and to make some of those changes.
Just a question. If you were able to implement one change in the way supportive care is given to delivered to amyloidosis patients, what would that be? Just one thing. I know that's a real toughie. And it's... Just one? Yeah, I know. It's a multitude, isn't it?
Well, the first thing that pops into my mind is more doctors and more clinic time, because... we're a 1.5 physician clinic that is growing and growing and growing. And so my physicians come 1.5 times a month. And if I could fix that, just get more physicians so that I don't have to be on the phone telling these new patients that just got told they have this terrible disease, oh, and by the way, I can't see you for 2.5 months. I feel just as bad saying 2.5 months as I do when I tell them I'm sending them for a GI referral that's going to take 6 months, or maybe a neurological referral that's going to take 3 to 6 months. I think that's the one gap I would like to change, is get these patients in, get them seen, do the teaching, give them the resources to deal with this disease. And that's the gap I would fix, if I could.
Thanks, Deb.
So Freya and I were talking earlier. We had a whole pre-conversation before we even got up here. But one of the things we would love to see is, for example, in the chronic kidney population, they have a multidisciplinary clinic. So when patients arrive, they see a doctor, they see a nurse, they see a dietitian, they see a social worker, they have access to a PT and OT, and it's all one appointment. And the patient stays in one place, and the staff rotate around. And so we would love to see something similar developed with amyloid patients, where you come in, you see your doctor, you see the nurse, you see everybody all at the same time. So it's more of a clinic setting as opposed to or a multidisciplinary clinic setting.
And I think that's to your point there, Kathleen, that's something that is in progress and that we hope to make a reality in the coming future, because often a person will go to, say, Dr. A, say the cardiologist, he's maybe 2 hours away on the east side. Maybe the neurologist is 3 hours away on the west side. So for a patient, that's an awful long day, because you've got those travelling backwards and forwards. They're already weak anyway, and when you put in everything like that, their days are gone. Their days are gone, and they're really tired. So if we can get something like that going, that's going to be ideal. And even if we do a hub and spoke in each of the provinces and then roll it out from there, yeah, but we'll get there.
And also, what can we do in the meantime, right? Because that is ideal, but how feasible that can be with the resources that we have, right? So that is a challenge. So I think from the perspective of the clinician, what I would like to see as a gap is that at least we have direct referral pathways. That I know that this patient, at least I know my nutritionist that is going to be helping my patient, my psychosocial worker that is going to be working with my patient, who's going to be my GI doctor working with these patients. Because sometimes for us, we don't have a specific amyloid GI. What we're going to do is we're going to refer to general GI, and it might take 7 months. And as the physician might not have any experience with amyloid, right? Which is fair as well. This is something that we start to learn in different specialties. So, but at least if we have our champion in each center, in each province that can handle these. And in most of places, I think now we're starting to know who can help us in certain areas. So what I will ask you is, whenever if you know somebody that is starting with this journey, ask for this, ask for that, get to see this person, get somebody to help you or give you guidance with physical activity, with nutrition, etc. I think for now, trying to work with local champions.
Absolutely, absolutely.
I think, too, somehow increasing support for the caregivers, because I feel like we spend so much of our time tailoring what isn't really out there to each individual patient, that by the time we're done with the patient, we don't have time, or the caregiver kind of gets forgotten, which really isn't fair, especially in Ontario, where a lot of the care does fall to the caregiver, and so somehow building support for those people as well.
Absolutely. Yeah, great points. Now, I think if you guys are okay, maybe members of the audience may have some questions, and hopefully we've got some answers. Merv, can you grab one of the mics and bring over? Shame, thanks, Fernando. Sorry.
Thank you. So, Doctor, you talked a couple of times about champions. Where do we find champions? Where does a patient reach out to find these champions that you're talking to? I would love to know that.
Yes. So I think there's always somebody that will be kind of leading the treatment, leading the patient, like setting up the appointments. What I will say, or that's not.
Well, sorry. What if the treatment hasn't started? Where's the champion that's going to lead you that pathway?
So if treatment hasn't started, but there's somebody already leading the diagnosis, right? So before we start treatment, we need to confirm the diagnosis. So that person that is leading the diagnosis, that will be the person, right? Because at that time, while we are investigating, we can do other things, because we know the referrals will take time. So at the same time, we can start asking, okay, who's the person that we can seek for nutrition? Who's the person that can guide us with exercise? Obviously, sometimes if treatment has not started, we need to make sure that there's no other concerns, clinical concerns before. But I think the nutrition, we don't need to wait at all. We need to refer the patient with psychosocial support. We can refer the patient immediately. Right? For exercise, we do need some clearance before, but I think asking the lead physician that is diagnosing the disease at the beginning might be the first person, or the person that you're dealing with directly. It might not be the physician, but might be your nurse in this case, that it will be saying, okay, who else can we get help?
Unfortunately, I'm finding I'm digging. In Toronto, we don't have, I think there's only the one clinic at St. Mike's, is that correct? Like specifically amyloidosis clinic?
No.
No?
The amyloidosis is also being managed at Sunnybrook and at UHN as well.
Yep.
And actually, the one that has been longest has been at UHN. So there are others.
The Peter Monk, that's what you're associated with?
Yep.
Yeah.
UHN, yeah.
Okay. Yeah, okay.
But I mean, if in your case you're in that process, in St. Mike's they have nutritional support, they have all the services. We just, or if the doctor that you're dealing might not be, the communication is not great with the family doctor, at least try to find another person that might be your champion, right?
Sometimes what we have to be the squeaky wheel. So when you don't get the answer, just, yeah. Any other questions?
I've been complaining for a number of years to specialists about all of the symptoms, and one cardiologist said it's in my head. My family doctor had to Google what the disease is when I was told I have it 2 months ago at UHN. Sorry. And I was only told you have the disease, it's early stages, you don't qualify for the medication yet, come back in a year. And I'm finding out that there are in fact resources, and I would love to exercise more. I was fit all my life. I had spinal stenosis surgery 2 years ago, and I asked the doctor a few weeks ago, is it connected to the ATTR, and he says, yes, absolutely. But he gave me zero resources, nothing. And your doctor here, who's affiliated at Peter Monk, I'd like to know, how can I be an advocate when I was given zero resources about anything? And it's a bit disappointing because I'm a doer. I would love to play hockey tonight, but it's not going to happen. Thank you. So if you can fill me in and tell me where and how and who to call.
So first of all, I would say I'm sorry because, we were talking about what is ideal, but that ideal is not always the reality, right? So what I will ask you, and I think you mentioned the word, be an advocate. What I can tell you, if you already have the contact of the clinics, you can ask even your family doctor to be referred to a cardiac rehab program. You can ask your cardiologist to be referred, and these are direct referral. You can even mention my name if you want, and we can make sure that you get into the program. So how? By just getting into the rehab program, being referred. That's the only thing we need, and then we will start there. What's it called? It's just the Cardiac Rehabilitation Program, Toronto Rehab. We're located at 347 Romsey Road. So anybody from your circle of care can refer you. It doesn't need to be the cardiologist, can be the family doctor, can be the neurologist, can be the surgeon. The only thing we need is a referral to be able to be part of your care. But if you need any information, I can give it to you separately. Happy to do it.
Is there any other questions from anyone in the room?
Yes, please.
Oh, my apologies, sorry.
I want to thank the panel very much for some very insightful comments. I had one point of curiosity, so how does neurology fit into the interdisciplinary care? I know in my case, a lot most of my symptoms definitely have a neurological impact and a very severe one. And past that initial diagnosis from neurology, which was very important, I'm not sure how prevalently the neurologists are featured in the ongoing care.
I can't speak for Ontario, but I can speak for Calgary. And automatically when they come to see us, and especially if they're hereditary ATTR, the referral goes to the neurologist for the testing, like the EMG and the nerve testing. And our neurologist in Calgary, Dr. Christopher Hahn and Gordon Jewett, they're absolutely amazing physicians. They see the patients as soon as they can. I think in about 6 weeks is their timeline, which is really good for Calgary. But they play a really important role, and I think Dr. Hahn sits on, he and Dr. Fine developed the Calgary amyloidosis group, where all the physicians and hematologists and everybody gathers once a month. But they play a pretty important role in Calgary.
Six weeks is an excellent turnaround time. That's absolutely awesome.
Yeah. And they just have a special interest in the hereditary portion of it. So they actually we take a backseat to most of the hereditary folks because they have so much more neuro involvement. So we kind of let the neurologists guide their care, and then we step in if it's a joint, nerve, and heart. But most of them generally suffer, unfortunately, from the nerve side of it. Yeah.
Yeah, we also do an automatic referral to neurology at the Heart Institute for patients who have hereditary TTR, and we just in the past month or two now have a neurologist who has a special interest in TTR amyloid, and we actually even have a shared list of our patients to make sure that the patients who have hereditary TTR, at least, or whoever's seen in his clinic, is being followed more routinely. And I think too, in follow-up to maybe some of the other comments, if you've asked something and you've been followed in an amyloid clinic, and it's been a couple months or even a couple of years, maybe ask again and advocate for yourself, because this is such a rapidly evolving landscape, and there's so many things that are coming down the pipeline or that have changed from when, I know Deb said 13 years, I'm only 5, but we're very different today than where we were 5 years ago. And so if the answer was no, or we don't know 5 years ago, ask again, because there's so much more that's coming out and that we're learning that we're more than happy to share. It's just maybe we forgot who asked or who we've said no to previously.
Okay, and there was a lady down here that had a question.
Jan's got her hand up.
Yeah, Jan. Murphy, yeah. Thanks.
Thank you. Thanks so much to the panel. It's been very helpful to hear your thoughts. I have 2 questions. They're both sort of connected to each other. And the first is we've heard from all of you actually in your own way talk about that sort of overwhelming sense of information overload when you're first diagnosed with amyloidosis. So the first question is, do any of you have any experience in or do you know of anyone else who's doing any work in this area where you're assessing patients' readiness to learn and then really targeting very specific information at certain points according to their readiness to learn? So that's the first question. And the second question is, do you have any advice on managing expectations? So, unfortunately, it seems like, in particularly with GI symptoms, that sometimes that we're sort of grasping at straws. And so how do you manage expectations when there really sometimes isn't, a great solution?
I didn't hear half the first question, so I'll answer the second one. Aging is not kind. But as far as expectations, when patients ask me, what can I expect down the line, Deb, I'm pretty honest with them. Thankfully we have treatments now, but 10 years ago we didn't. And it was a matter of saying, yes, you're gonna get worse, and you're gonna have to kind of take it day to day. Now that we have treatments, what we generally tell patients on, what can you expect? Well, you're going to probably not feel any better on the medications that you're receiving, for one thing, but the good news is it's going to stop the disease from getting worse, and theoretically, in my brain anyway, it's going to be more of a point of listening to your own body. So managing your own body and saying, okay, I feel really good today, and I'm going to go play hockey, or I'm going to go take a nice long walk. Maybe the next day you get up and your body's saying, I don't feel so good today, I'm tired. So you really need to listen to you to be able to do the things that you want to do going forward. So you're going to have good days, you're going to have bad days. Managing those is going to be up to you and your loved ones or whoever's with you. And just listen to your body. And if you're feeling good, do what you want to do. If you're not feeling good, don't. And cardiac rehab plays a huge role in this, in helping patients being able to, manage their day-to-day life and get more energy so they can do more things. But that's my take on managing anyway.
Very good. Yeah, one of the things that I used to do, Deb, that I don't do anymore, I used to always fight those bad days. But what I found out was happening was I was spending so much energy pushing myself that I would end up really not good. Instead of just having the one day that was bad, it would maybe develop into 3, 4, 5 days. So I've learned, for the most part, although my husband will tell you that I'm quite stubborn, I usually do listen to my body, and for the most part, if I'm not having a good day, let it be, just let it go. Having a good day, enjoy it, make the most of it. And the same goes for eating. Like if I have a day where I'm really enjoying my food, it's like heaven on earth. So, and I'm sure many people can acknowledge that as well. But yeah, but well said.
That goes for caregivers too.
Absolutely.
I mean, those of you that take care of amyloid patients. Yeah, sorry, I always think I have a big mouth, but I don't really. The caregivers are just as important as the patient, really, in this disease, because you spend so much time taking care of your loved one that you don't take care of yourself. So the same thing goes for caregivers. You're having a good day, great. Help that patient out or help your loved one out. But if you're not having a good day, you need to tell them and say, I'm not having a good day today. We're going to just kind of tone it down, and I'm gonna do a little something for myself.
That's important.
Yeah,
really
it's
important.
very important.
Yeah.
Because you are their supportive care, and you really do need to take care of yourselves.
Yeah, my husband was, or is, one of those people that didn't want to go out and meet other people and do other things. And I basically just kept on pushing. And I'm delighted to see where he is today and the associations that he's joined. And now he gets to go his place and do his thing. And I think that's delightful. And it's what he needs too. So he doesn't need to sit and babysit me all day. Don't need that. So it's great. So to your point, absolutely, Deb.
Yes, first of all, I'd like to thank you for this conference. I have this disease, but I keep asking myself, when is this going to arrive? I really have a lot of problems understanding the future. I think Johnny Carson said everything is about timing, and I really don't know the timing of this, the progression. I search the internet a lot, and intellectually I kind of understand that something's happening in my bloodstream, but I don't really know where I'm going and how soon it's going to happen. And I am connected to a cardiologist, and he's a pretty busy person, and he's the one who made the diagnosis. But short of enrolling in your program, doctor, which I think I'm going to do, but I live 200 kilometers north of Toronto. Now, I know everything, I'm rambling here, I know everything happens in Toronto, and I recognize that, but there's a huge country, nation, province out there. Do we all trundle down to Toronto to find out what the hell's going on?
No, and I think something that we try to do also in our program is also to cover those areas where we cannot expect people to come, to travel 200 kilometers just to see us, right? But there are other programs, smaller programs in North, in Barrie, there is one. So we work as well with other programs. A lot of the referrals that come to us, that are outside of our region, we refer them back to others. And for example, I have patients from New Brunswick that we were able to find the connection to their program there, right? So we can help to guide you at least what you can do. Sometimes with just one assessment, right? You might not be enjoyed for the 6 months that our program lasts, or the 4 months, sorry, but we are able to provide you some guidance what you can do. So I think that part of looking for support doesn't mean just one place or the other. We can find opportunities that could help.
Great.
If I can maybe comment on your question about prognosis, is what it sounds like, and not knowing, what's coming and when it's going to come. Another portfolio I do oversee is our cardiac palliative program, and I'm not saying that as the end of life, but I'm saying, as someone who's diagnosed with cardiac amyloid and any illness, I think it's really important to do some kind of advanced care planning, and whether that's as simple as choosing a power of attorney, you can start thinking about, we say decisional readiness is other things that we talk about, these major life decisions, and which can certainly change. But I think that's really important, and it's something I definitely do speak to my patients with amyloid about, and maybe a little bit more comfortably because I do oversee both portfolios. But one thing we always tell patients, especially with any heart disease, we don't know. And we really don't know with patients with cardiac amyloid. It's so different for each patient, and I think we've seen that here today, which can be quite frustrating for patients, not knowing what's coming and when it's going to come, but being ready for those sort of major life events that can really happen to anyone. You don't need cardiac amyloid, but at least thinking about it and talking about it with your family members, friends, or healthcare providers, I think is really important.
Yeah, and just to complement the first question, I think part of what is being discussed in the other side is understanding these markers of progression, that if there are many and we don't know which is best. So we're still learning with this condition. As now, some of the treatments now, we have more experience with them. Now we're starting to understand a little bit more. So what I would recommend, and what I recommend to all my patients with or without amyloid, is exactly that, step by step, right? We don't know what is going to happen in 5 years, but we can know what it can be our next step. What is the thing that you can control today to make you feel better? And that's what I tell people. Focus on the things that you can control. The things that we cannot control, there's no point, right? So those little things, what are you eating? How are you eating? What are you doing for yourself today? Little actions on the day-to-day, I think, can make a difference.
I think we've got time for one more question. Does anyone else have a question for any of the panel? Please. Thanks, Fernando. As you say, one step at a time.
Hi, thank you very much. My mom just got diagnosed 3 weeks ago, so I'm very new to this process. I was wondering if you could tell me, because she got diagnosed from a biopsy of her bladder, and of course the urologist didn't know what to do with this information, so he sent her to a rheumatologist who called and said, "Oh, I don't deal with this." Now we have an appointment with a cardiologist, a oncologist, and a GI doctor. I'm just wondering, first, because she just got diagnosed, her mother had it 30 years ago and died of it. She just has the general, do I need to get her genetic tested to know what subcategory she has, and how do I do that? And second of all, what would you say would be the first 3 steps that I should be taking to help her?
And just from the medical part, obviously, before I will see the doctors, they need to give you options because, yes, the genetic testing might be done, but there are other things that need to make sure, right? The stage of the disease, what kind of type. So there are kind of a diagnosis process that you will go through. Well, your mom will go through, sorry. So I will just wait, and obviously you can ask the question, is this something that we require genetic testing? The genetic testing takes time. So there are a lot of things that will happen before that. And also, what we are discussing today, when you are able to see I think the cardiologists and the oncologists, what other resources do we have available in the meantime while we wait? Is there anything that we need to check with the nutrition? Do we need psychosocial support? Is there any way to get us for some physiotherapy if it is needed? So I think asking those questions will be very helpful, rather than because the genetic testing might be that option, but first we need to get there. No?
I think we're all good. So thank you very much, everyone, for participating. Thank you, Deborah. Thanks very much, Freya. Thank you, Kathleen. Thank you, Fernando. I think it's been a wonderful presentation from you guys. Appreciate it. Okay.
And go, James, go.
Yeah.
Game 7.
Thank you.